Hello everyone, welcome back to my channel. So today we will be discussing the pending questions from 2013 base paper. So we are going to discuss only the gynecology questions, okay? So let's begin. A 58-year-old female patient came to the antenatal clinic complaining of bloody discharge, light red discharge from the genital tracts. Menopause is 12 years. Gynecological examination revealed age involution of external and vagina. Uterine cervix was unchanged and there were scanty bloody discharges from the cervix. Uterus was of normal size. Uterine appendages were not palpable. Parametria were free. So what will be your most likely diagnosis? So here the points to be noted is, first of all, the age of female patient. Okay, so she's a 58-year-old female, and now she already got her menopause. That means her menstruation was already done or completed, and menopause is almost 12 years. Okay, and now after 12 years of menopause, now she is having bloody discharge from the genital tracts, and the gynecological examination says that as per the aging, okay, as the age goes on, there will be involution of genitals. So that such kind of age related involution of genitals are also seen. Okay, it is due to menopause. But now what is the cause of bleeding again? Okay, so always remember the most common cause of post menopausal bleeding is always endometrial cancer. So this is a point to be always kept in mind whenever a lady bleeds after completing her menopause. Endometrial cancer or uterine cancer is the most common reason, and the most common cause of post coital bleeding. Whenever a lady bleeds after having coitus, it is because of cervical cancer. Okay, the most probable cause will be always cervical cancer in case of post-coital bleeding, but in case of post-menopausal bleeding, it is always endometrial cancer. So now let's see the options. The options are uterine carcinoma, abnormalities of menstrual cycle of climacteric nature, atrophic colpitis, cervical carcinoma, granulosa, cell tumor of ovary. As I already mentioned, cell tumor of ovary, there are no much signs in the question saying about the ovarian tumor. Okay, then as I already mentioned, cervical cancer is seen as post coital bleeding, not in post menopausal age. Okay, and this happens in the reproductive age. Okay, now atrophic colpitis. See, atrophic colpitis basically means the vagina and the external genitalia are getting atrophied. That is a normal process which happens in post-menopausal time period, and that will not result in bleeding and all. No bleeding in this case. There will be vaginal irritations and vaginal itching and all. Okay, but not bleeding. Abnormalities of menstrual cycle of climacteric nature. See, there are no more abnormalities needed because in question she says that the history says that menopause was 12 years back. Okay, so this can be ruled out, and we already know the most common cause of post-menopausal bleeding is uterine carcinoma. Now moving on, 48. The results of a separate diagnostic curettage of the mucus of uterus, cervix and body made up in connection with bleeding in a post-menopausal period. The scrap of the mucus of cervical gland revealed no pathology in endometrium. The highly differentiated adenocarcinoma was found. Metastases are not found. So what is the most correct treatment? Okay, so here in question already the diagnosis is given. It is a highly differentiated adenocarcinoma, and they also mention there is no metastasis. So always remember, when it comes to the endometrial cancer, the staging means how we determine the stage of cancer. That is always done surgically. So in order to determine just the stage of cancer itself, we basically do hysterectomy, bilateral salpingo-oophorectomy, and even we will dissect any of the enlarged lymph nodes. Okay, so even the staging for the purpose of staging, all these surgical procedures are done. So if all these things are removed, like both the tubes are removed or both the ovaries are removed, uterus is removed, then obviously the treatment is always maintained in the post-operative management. Okay, so the post-operative management in patients with endometrial cancer is always radiotherapy. However, whenever there is no metastasis, there is no need to give radiotherapy. Okay, so in that case, in the question, it is clearly mentioned metastasis is not found. So in that case, we can go for surgical treatment along with that hormonotherapy because metastasis is not found. In case of metastasis was there, we will definitely do radiotherapy. Okay, so it will be surgical and radiotherapy in case of metastasis. But if metastasis is not there, then surgical and hormonotherapy. Okay, so that is again a clear cut question. Now, next question. A 27-year-old woman complains of having the disorders of menstrual function for 3 months, irregular pains in abdomen. On bimanual examination in the dextral appendage, the range of uterus, there is an elastic spherical formation, painless, 7 cm in diameter, and ultrasonography says that in the right ovary a fluid formation is seen which is 4 cm in diameter and it is smooth, and what kind of method of treatment is most preferable. Okay, so again it is clearly mentioned that there is an elastic spherical formation which is painless and that is around 7 cm in diameter. And when we checked the ultrasonography in right ovary, we already found a fluid filled formation which is around 4 cm in diameter. So this clearly mentions that this is an ovarian cyst. Okay, so basically what is ovarian cyst? Whenever there is some fluid filled sacs within ovaries, that are basically ovarian cyst. So in this method, in this ovarian cyst, they are asking what kind of treatment can you go for. So for that we should have a basic idea about some ovarian cyst. First of all, ovarian cyst can resolve itself within a period of 6 months. Okay, so even if we don't give up any treatment, it will go away itself. Okay, so we are giving oral contraceptive pills only to prevent the recurrence of future cyst. So we don't want the cyst to reoccur again. That is the reason why we give oral contraceptive pills. Okay, but in that case also there are basically 2 types of cyst. Ovarian cyst can be functional ovarian cyst and non-functional ovarian cyst. So the one which does not need particular treatment but we can just give OCPs for preventing recurrence is basically functional ovarian cyst. It can be theca luteal cyst, it can be corpus luteal cyst, anything. But non-functional ovarian cyst, these are basically dangerous varieties. Okay, they need particular treatment and basically they need surgery. And this is basically endometrial cyst. Okay, endometrial chocolate cyst, which is seen in endometriosis. So these are special cysts which need special treatment and that have to be removed surgically. So here we are dealing with functional cyst because in question they haven't mentioned anything like chocolate cyst. They haven't mentioned any particular name of cyst. So this is basically a functional cyst which just need oral contraceptive pills. So just a prescription of estrogen gestagen complex, that is basically the oral contraceptive pill for 3 months with a repeated examination is quite enough for a functional cyst. So there is no need of chemotherapy for a functional cyst. Anti-inflammatory therapy won't help unless the patient have pain or anything. Operative therapy, as I said, surgery is always given for non-functional cyst. Okay, not for functional cyst. And observation of patient, obviously observation is needed, but this is not a complete choice because we can give OCPs. This is the best out of that because we can give OCPs, oral contraceptive pills, to prevent the reoccurrence of cyst. Now moving on. A 48-year-old female patient complains about contact hemorrhage. Speculum examination revealed hypertrophy of uterus cervix. It resembles of cauliflower. It is dense and can be easily injured. Bimanual examination revealed that fornices were shortened, uterine body was non-mobile. What is the most probable cause? Okay, some points to be noted over here is she's 48-year-old, okay, and she's having a contact hemorrhage. Okay, so when we examine the cervix, there is a contact hemorrhage. The bleeding starts when we do bimanual examination, and speculum examination shows that there is hypertrophy of cervix uterus, and because of this hypertrophy, now cervix is looking like a cauliflower. Okay, and it can be easily injured. The fornices were short and uterine body was non-mobile. So these are the unusual things you can find here. Now they're asking what will be the most probable cause. So let me begin with the options. First of all, endometriosis. See, endometriosis can never be an option here because endometriosis basically means there is a growth of endometrial tissue outside the uterine cavity, which will always present with profuse bleeding during menses, and there is very bad pain. Okay, so we call it as dysmenorrhea. So very painful menstruation, and also the vaginal discharge can be a chocolate colored vaginal discharge. Okay, so all these things are very much contraindicated with the question. Okay, then metrofibroma, this is basically fibroids. Again, fibroids will have heavy menses. Okay, the menses bleeding will be very much more, and even the uterus size can be increased. So again, the question, what is given in question and option does not match at all. Cervical papillomatosis is basically HPV infection. So again, the question does not say whether the female was sexually active or was she treated for papillomatus diseases ever before, or whether she were vaccinated, or whether there was strain like 16 and 18. Nothing. The question doesn't say anything about that. Then cervical pregnancy. Again, cervical pregnancy is ectopic pregnancy only. So even in cervical pregnancy, ectopic pregnancy always presents with amenorrhea, abdominal pain, and vomiting. Okay, so these even amenorrhea is not mentioned in the question, so this is definitely not cervical pregnancy. Now we already know it is cervical carcinoma, but why is it exactly cervical carcinoma? What in question gives us an idea that it is cervical carcinoma? So for that, we need to know that for identifying cervical cancer, there are always 4 main signs. Okay, it will be hardness, it will be friability, fixation, bleeds on touch. So these are the 4 important points of identifying cervical cancer. Okay, these are the 4 cardinal points. So as I mentioned, bleeds on touch. Obviously they mentioned in the question contact hemorrhage. And there is fixation. Okay, that is why the uterus is non-mobile. And there is friability. Friability means the appearance of crumbled appearance. That's why they say due to hypertrophy of the cervix, it appears a cauliflower like shape. Okay, and then finally hardness. So now we can understand that all these cardinal signs of a cervical cancer are mentioned in this question. So because of that, we can clearly diagnose it as cervical carcinoma. I hope it's clear. Now moving on. Laparotomy was performed to a 54-year-old woman on account of big formation in pelvis that turned out to be one-sided ovarian tumor with a considerable omental metastasis. Okay, what will be the procedure? So again, I'm repeating the same point. Whether in case of endometrial cancer or ovarian tumors or ovarian cancer, in all these cases, staging is always done surgically. So just to confirm the staging of the cancer, we remove uterus, we remove ovaries from both sides, even we remove the fallopian tubes. Okay, and whenever if there is metastasis to any lymph nodes or anywhere, we will remove the part which already have metastasis also. So basically the treatment is in post-operative phase. The treatment lies in post-operative management. Okay, so now in this question it is clearly mentioned that there was one-sided ovarian tumor, along with that there is omental metastasis. So we already know we remove uterus, we remove both ovaries with tubes, and because there is omental metastasis, we have to remove the omentum also. Okay. So again, this is a very clear-cut question. So just know the what procedure is done in case of ovarian tumors as well as in endometrial cancer. Just for staging itself, we are doing hysterectomy plus bilateral salpingo-oophorectomy, and then if any more part is affected, we will remove that also. So this is a direct question. Now next question is a patriarchan complaints about pain in mammary gland. Palpation revealed 3 to 4 centimeter large infiltration, soft in the center. So what will be the cause of this? So she is having pain in mammary gland, and when we palpated, we are able to find a large infiltration. Okay, so infiltration, what does infiltration means there is an accumulation of something infiltrate. That infiltrate can be any foreign body, or that infiltrate can be on body tissues. Okay, so infiltrate always means an accumulation of something. Okay, and it is soft in the center. So let's see pleuritis. See, pleuritis is completely a different scenario where the patient will have chest pain, okay, cough, and retrosternal pain, all those things which are related with the respiratory system, not in the mammary gland. Birth trauma, there is no chance of birth trauma in the mammary gland. Retention of milk. See, milk lactostasis can happen because of not properly expressed breast milk, but in that case abscess formation is very much least seen. In this case there is no formation of infiltration. Okay, no formation of infiltration. Again, pneumonia, we all know the presentations. Then comes acute purulent mastitis. Okay, so this is acute purulent mastitis, that is why there is a large infiltration formation. And in between, I just want to remind you that if anyone need this PDF, then they can mail to skmedconcept@gmail.com so that I can send this PDF as well. Now the next question is, 2 weeks after labor, a patriarchan woman developed breast pain being observed for 3 days, and high examination revealed body temperature at the rate of 39 degrees Celsius, chills, weakness, hyperemia is seen, enlargement, pain, deformity of mammary gland. On palpation, an infiltrate was found to have an area of softening and fluctuation. So again, if you have seen my previous video, I am sure you know what is fluctuation. I already mentioned fluctuation is a sign of abscess. So if it comes in Bartholin's gland, obviously it is the abscess formation in Bartholin's gland, and if the fluctuation sign is seen in breast, it means that it is an abscess formation. So what is the most likely diagnosis? So again, the option seems to be a little tricky when we see E and B, because both are obviously phlegmatous mastitis means abscess formation only, but infiltrative purulent mastitis is the most likely diagnosis, because in question they already mentioned an infiltrate was found. That means already on palpation we found the accumulation of some infiltrates. Okay, so this is why it is an infiltrative purulent mastitis and not phlegmatous mastitis. And again, lactostasis, as I already mentioned, in lactostasis, that means in milk retention, there is no abscess formation and all. Then mastopathy is breast pain, and serous mastitis, it is the serous kind of fluid discharge from nipple. Okay, so nothing related with the fluctuation symptoms and all. Now moving on the 10th day postpartum, Puerperan woman complains of pain and heaviness in the left mammary gland. Body temperature is 38.8 degrees Celsius, and pulse rate is 94 beats per minute. And the left mammary gland is edematic. The supero-external quadrant of skin is hyperemic. Fluctuation symptom is absent. Nipple discharge drops of milk when pressed. Okay, so again this is a very clear-cut question, because see, the issue starts on the 10th day after delivery. Okay, and obviously it is given fluctuation symptom is absent. It means there is no abscess. Okay, so there is no abscess, and when we palpate and when we checked upon, we found that nipple discharging milk when we press the breast. Okay, this clearly shows that it is a case of lactostasis. Okay, so there is milk retention. Maybe she is not feeding on time, or maybe she is producing excessive milk than what the baby can consume. Okay, so these are the main reasons for lactostasis. So this is why the nipple is discharging milk when pressed. So in that case, we can just give antibiotic therapy. Why we are giving antibiotics? Because in lactostasis, which is also known as postpartum lactational mastitis, basically inflammation is there, and even there can be infection with Staphylococcus aureus organism. Okay, so Staphylococcus aureus is the most common organism which is reported in mastitis, in this lactostasis kind of mastitis. Okay, so this is why we give antibiotics, and obviously we have to express the breast milk. We have to suggest manual or any kind of expression of breast milk. So then that symptoms will be going over by time. So always remember, if there is no sign of fluctuation, there is no abscess. Okay. Then options also we can see: inhibition of lactation. There is no need to stop lactation. Okay, there is no point in stopping lactation when milk is already accumulated. Compressed to both mammary glands. See, that is a manual kind of expression. It depends upon the patient whether they can give manual expression or not. Then opening of the abscess. See, this is a completely wrong choice because already there is no abscess in question. Fluctuation sign is absent. So there is no point of opening the abscess and all. There is no abscess formation. Physiotherapy won't help in this case. So the best answer will be antibiotic therapy, because the most common organism causing is Staphylococcus aureus. Now next question. A 54-year-old female patient consulted a doctor about bloody discharges from genital tracts after 2 years of amenorrhea. So ultrasound and bimanual examination revealed no significant pathological changes. So what is the tactics of choice? So again, the point to be noted is her age. She's a 55-year-old female, and now she is having bloody discharge again after 2 years of amenorrhea. So since 2 years she was not having menstruation, and now after 2 years she is having bloody discharge again. So when we did the bimanual examination, everything was fine. There is no specific pathologies found. So what will be the tactic of choice? So already I mentioned, what is the most common cause of postmenopausal bleeding? It is always endometrial carcinoma. Okay, so endometrial carcinoma is the most common cause of postmenopausal bleeding. So if we know this point, we know what are the steps to be done. So when a lady comes with endometrial carcinoma, or if we have a suspicion that she may have endometrial carcinoma, transvaginal sonography is the first step done. Okay, but the investigation of choice is always endometrial aspiration biopsy. Even in case if we are not able to rule out cancer from endometrial aspiration biopsy, the gold standard is always fractional curettage. Okay, so if we have this much idea, we can easily solve this question. Now let's see. Contracting agents. See, we have to diagnose something. So for that purpose, giving tocolytics or whatever it is, no purpose. There is no need to do hysterectomy all of a sudden without even confirming. Okay, then estrogenic hemostasis. Basically, it means giving up some estrogens or drugs won't help. Stibit drugs, no point of these things. So already we know this is a direct one-liner type of question basically. So the gold standard for finding or confirming postmenopausal bleeding due to endometrial carcinoma is always fractional curettage, which is also known as fractional biopsy or selective fractional curettage and all. Okay. So always remember, the first step done is transvaginal sonography. The investigation of choice is endometrial aspiration biopsy, and the gold standard is fractional curettage. Now let's come to the next question. A 27-year-old woman presents at the maternity welfare center because of infertility. She had sexual life in marriage for 4 years, doesn't use contraceptives. She hasn't get pregnant. On examination, the genital development is without pathology. Uterine tubes are passable. Basal temperature is 1 phase during the last 3 menstrual cycles. Okay, so first of all, what is basically infertility? When a couple is not able to conceive within 1 year without using any sort of contraceptives, that is basically infertility. Now when we check this patient, she had a sexual life in marriage since 4 years, but she's not even using contraceptives and she's not able to get pregnant. Now the genital development is always without pathology. Okay, and the uterine tubes are passable. That means there are no issue with uterine tubes. Okay, so what I mentioned in previous video also, I mentioned whenever there is a case of infertility, the first step done is semen analysis, right? So if the semen analysis is normal, then we check for ovulation. Okay, and then we check for tube factors, whether the fallopian tube is fine or is there any adhesion formations and all. And finally we will check for cervical factors. So this much is known to us. So from that, let's see, her genital development is without pathology, uterine tubes are passable. That means the tubes are passable, there is nothing wrong with the tubes. So this is ruled out, tubes are fine. But there is an important point which is given. The basal temperature is 1 phase during the last menstrual cycle, which shows that there is some trouble with ovulation. Okay, so now what is this basal temperature and why does it show a sign of an ovulation? See, to know properly whether a female is ovulating, there are many different techniques of finding. So out of that, the first step is to determine the basal body temperature. So always a female who have proper ovulation, okay, who have a proper ovulatory cycle, they will always have a biphasic pattern of temperature. That means at the time of ovulation, their body temperature will be raised 0.5 to 1 degree Fahrenheit. Okay, and then this rise will remain throughout the second half of the cycle, and then it falls 2 days prior to the next cycle. So this is called biphasic pattern. So remember, whoever ovulates, whoever have a complete ovulatory cycle, they have a biphasic pattern of temperature. So in case if we found that there is no rise of temperature throughout the cycle, that means if there is monophasic temperature found, it means it is a clear-cut sign of an ovulation. Okay, so this is a very much clear-cut sign. So always remember, an ovulating female needs a biphasic temperature pattern. But if she is monophasic, or as mentioned in the question, the basal temperature is 1 phase, it is a clear-cut sign of an ovulation. So basal body temperature is basically one of the method to determine whether a female is ovulating or not. There are other studies as well. We can study the cervical mucus. So whenever the estrogen is more, the cervical mucus will show us a ferning pattern, and when progesterone is more, this cervical mucus will lose its stretchability and all. And even we can do vaginal cytology studies, hormonal estimation, endometrial biopsy, ultrasonography. All these are methods to study and determine the female is having a proper ovulation or not. So out of that, the most prominent one is basal body temperature. Clear? So now getting back to our question. Now when we read it, this is a clear-cut question. See, basal temperature is monophase. Okay, it's 1 phase during last 3 menstrual cycle. So what is the cause of infertility? An ovulation is the cause of her infertility. I hope it's clear. Moving on. 43-year-old woman complains of contact hemorrhage during the last 6 months. Bimanual examination showed cervix of the uterus is enlarged. Its mobility is reduced. Mirrors showed the following. Cervix of the uterus is in the form of cauliflower. Schrobeck and Schiller's test are positive. What is the most probable diagnosis? Again, this is a repetition of question only, except for one point. They just added that Schrobeck's and Schiller's test are positive. So we already learned the 4 cardinal signs of cervical cancer is friability, okay, cauliflower appearance because of hypertrophy, bleeds on touch, contact hemorrhage, fixation, that is basically non-mobility, and hardness. Okay, and to that you can add that Schrobeck and Schiller's test are basically used to diagnose cervical cancer only, and if those tests are positive, obviously it means it is the cancer of cervix of uterus. Okay, Again, no history suggesting cervical pregnancy. As I mentioned, cervical pregnancy is a type of ectopic pregnancy, and it should always present with amenorrhea, abdominal pain, vomiting, and all. Then no, not leukoplakia. Leukoplakia is a white color candidal infection. Basically, there is no sign of candidal infections in the question. Nascent fibroid. As I mentioned, fibroid always present with heavy bleeding and the increase in uterine size and all. Polyps also, it is same as that of fibroids. Now, a 26-year-old woman gave birth to a child 6 months ago. She applied to gynecologist complaining of menstruation absence. The child is breastfed and vaginal examination shows uterus is of normal form, dense consistence. What is the most probable diagnosis? See, this is a clear-cut sign of lactational amenorrhea. She just gave birth 6 months ago. So we already know after delivery around 6 months there will be lactational amenorrhea, right? There is absence of menstruation because the mother is excessively feeding the child, and there is no history of any other things. Like suppose if it has to be Sheehan syndrome, there should be a history of postpartum bleeding. Okay, so if you have seen my previous video also, you can see that Sheehan syndrome questions are having a history of postpartum bleeding, because only this postpartum bleeding can cause necrosis of anterior pituitary. Okay, so you can add up a point over here. I got an interesting inquiry suggesting why only anterior pituitary is affected. See, hypothalamus is basically connecting to pituitary, and pituitary has both anterior and posterior pituitary, right? So hypothalamus is connecting to posterior pituitary through nerve fibers. Hypothalamus is connecting to posterior pituitary through nerve fibers, but hypothalamus is connecting to anterior pituitary through blood vessels. Okay, so this is why when there is postpartum bleeding, suddenly it will result in ischemia causing anterior pituitary be affected. So in that case, such a history should be there. So that kind of history is not there. Then gestation. See, she already gave birth, so she is not in the period of gestation. Asherman syndrome. Again, Asherman syndrome is a complication which happens due to excessive dilatation and curettage. Okay, this happens when we are trying to remove morbidly adherent placenta using curettage. So what happens? After an year, it will result in adhesion formation in uterus. Adhesion formation in uterus. So this is why Asherman can be cut out, because the question does not mention pseudo-amenorrhea. This is not pseudo-amenorrhea. Okay, this is not a false absence of menstruation. This is just a physiological amenorrhea which is happening due to lactation. Now moving on. 59-year-old female patient applied to a maternity welfare clinic and complained about bloody discharge from the genital tracts. Postmenopausis 12 years. Okay, and vaginal examination revealed that external genital organs had signs of age involution. Uterus cervix was not erosive. Small amount of bloody discharges came from the cervical canal. Uterus was of normal size. Uterine appendages were unpalpable. Fornixes were deep and painless. What method would be applied for the diagnosis specification? So again, this is a repeated question. See her age. She is in the postmenopausal women, right? Postmenopausal was 12 years back, and now she is bleeding again. Okay, so already I said the most common cause of postmenopausal bleeding is endometrial cancer. And what is the gold standard? The investigation of choice is aspiration biopsy, but what is the gold standard? Fractional curettage. So this is also known as separated diagnostic curettage. Okay, ureteroscopy is colposcopy. All these are used to see the vaginal area and also the sac over there, okay, and not a laparoscopy. Even there is no need of puncturing and all, okay. So already we know this is a direct question, we know its explanation. Now moving on, a 25-year-old woman complains of profuse foamy vaginal discharges, foul burning and itching in genital area. She has been ill for a week, extramarital sexual life. On examination, hyperemia of vaginal mucus, bleeding on touching, foamy leukorrhea in the urethral area, which is the most probable diagnosis. Okay, so she is having a very profuse foamy vaginal discharge. It has a foul smell, she has itching, and it does have bleeding. But what to be an important point over here is there is a foamy leukorrhea. Okay, so the vaginal discharge is basically looks like it is full of foam. Okay, now let me speak about what can you find in gonorrhea. Okay, so gonorrhea you can see mucopurulent discharge. Okay, and what about vaginal candidiasis? It is a fungal infection. So here you can find cottage cheese like vaginal discharge. Okay, and bacterial vaginosis. First of all, bacterial vaginosis is not an inflammation. It happens because there is the bacteria present in vagina got altered, maybe because of excessive douching and all. Okay, so bacterial vaginosis, no itching because it is not an inflammation. But what is you can find here is it has a very bad fishy smell. Okay, fishy smell or fishy odor. So this fishy smell is very much characteristic for bacterial vaginosis. Again, chlamydiosis is also having same mucopurulent discharge only, because mucopurulent discharge, the first major cause is gonorrhea and the second cause is chlamydia infection. So this is same thing. So you can remember here, frothy green vaginal discharge with a musty malodorous smell is always a sign of Trichomonas vaginalis. Okay, so always remember, foamy leukorrhea is produced by Trichomonas vaginitis. Okay, vaginalis is the organism name, so the situation is Trichomonas vaginitis. Okay, in gonorrhea and chlamydia it is a mucopurulent discharge, and in candidal infection of vagina it is cottage cheese like discharge, and finally in vaginosis you will not find any inflammation or itching. You can just see fishy smell. So I hope it's clear. Now moving on, a woman consulted a doctor on the 14th day after labor about sudden pain, hyperemia and induration of the left mammary gland. The body temperature rise up to 39 degree, headache, disposition, fissure of nipple, enlargement of left mammary gland, pain on palpation. See, again the question says that the woman comes to the hospital 14 days after labor with a sudden pain, and when we checked there is fissuring of nipple, there is enlargement of left mammary gland, and also there is pain on palpation. So first of all, no fluctuation sign, so no abscess. So we can cut out even phlegmon, we can cut out, because no phlegmon basically means there should be an abscess formation, right? Even if it is phlegmon or infiltrative, whatever, there should be an abscess formation. Then fibrous adenoma. See, adenoma is a benign tumor of mammary gland. In that case, there should be a rubbery mass. Okay, a rubbery mass should be palpated. Such kind of rubbery mass is not found. In question, there is only pain on palpation. Again, cyst with suppuration. Again, if there is any sort of abscess formation, there will be sign of fluctuation. This is not a breast cancer, because we know how breast cancer presents with, right? Now, this is a clear-cut sign of lactational mastitis. As I already mentioned, the time the patient comes to the clinic also matters, because this lactational mastitis mainly happens after 1-2 weeks after delivery. Okay, and this is mainly due to milk retention, and this will present with fissuring of nipple. When we palpate, the drops of milk can be pressed out, And also the most common organism causing this is Staphylococcus aureus infection, lactational mastitis. Okay, so this is a repetition only. Now, a 13-year-old girl consulted the school doctor on account of moderate bloody discharge from the genital tracts which appeared 2 days ago. Secondary sexual characters were developed. What is the most probable cause of bloody discharge? See, she is just a 13-year-old girl, and we know that puberty starts from 13 years, right? And basically the secondary sexual characters are also developed. So there is no need to think about a pathology because of her age, and the secondary sexual characters are already developed. So this is just a beginning of menstruation. There is no hemophilia. See, hemophilia, there should be a different scenario in which there can be knee joint affected, family history, okay, and bleeding from other sources also, other sources of body, like it can be a skin rupture while the child was playing and it fell down and bleeding couldn't stop, such things. Then juvenile hemorrhage or juvenile dysfunctional uterine bleeding, this will have heavy menses. Okay, there will be too much of bleeding in this case without any organic cause. So again the presentation of question will be different. Never, endometrial cancer is never possible in a 13-year-old girl. Okay, then Werlhof's disease, this is an immune thrombocytopenic purpura which have no relation with the question given. Okay, now the next question is, during examination of a patient, masses in the form of condyloma on a broad basis were found in the area of perineum. What is the tactics of doctor? Okay, so first of all, condyloma is an STD, condyloma acuminata or warts. It is also known as warts, which are caused by human papilloma virus. Okay, and which strains cause that? The low oncogenic one. The low strains cause like 3, 6, 11 and all. Okay, so these are basically sexually transmitted disorders. So we have to send the patient to dermatological and venereological center. Okay, because when we see this thing also, when we come upon this kind of STD, we have to do a particular test known as VDRL test to confirm these things. But if the question was a little more clear about asking like what is the method of treatment you can choose, it will be always cryotherapy. Okay, so the treatment will be cryotherapy. So basically cryo destruction of condylomas are the treatment. Moving on, a 28-year-old woman has bursting pain in the lower abdomen during menstruation. Okay, so there is a severe pain she faces during menstruation, and there are chocolate like discharges from the vagina. It is known from the anamnesis that the patient suffers from chronic adenitis. Bimanual examination revealed a tumor-like formation of the heterogeneous consistency, 7 × 7 cm, large to the left of uterus. Formation restrictively movable, painful when moved. What is the most probable diagnosis? Okay, first of all, she have a very bad pain during menstruation, and the main point to be noted here is there is chocolate-like discharge from vagina, and when we checked upon, we found there is a tumor-like formation which is around 7 × 7 cm large to the left from the uterus. Okay, so this formation is partially movable and it is very much painful. So this is again a clear-cut sign of cyst. So this is what they are mentioning. The cyst is, they are mentioning it as a tumor-like formation, okay, which is seen left from the uterus, and the diameter is also given. It is around 7 × 7 cm. Now, as I already mentioned, we have to know that cyst is of two types, functional and non-functional cyst. Non-functional ones are the chocolate cyst, dermatoid cyst, malignant cyst. And the functional ones are theca luteal cyst, follicular cyst and corpus luteal cyst. So as I already mentioned in the previous question, these functional cysts, they will resolve itself and we just have to give oral contraceptive pills to prevent further reoccurrence. But in case of non-functional ones, we have to always resort to surgical management. Okay. So now moving to the question, this is a clear-cut sign of endometrioid cyst, because I already mentioned the chocolate appearance of vaginal discharge is a sign of endometrial cyst, which happens due to endometriosis. Okay, so you can note down this point. Chocolate cyst is seen with endometriosis. Okay, and it is also known as ovarian endometriomas or even endometrioid cyst. So basically these chocolate cysts, they contain blood and menstrual debris. So always have a correlation between chocolate cyst and endometriosis. And we know that endometriosis means it is the growth of endometrial tissue outside the uterine cavity. So in case of endometriosis, there is always a severe pain and heavy bleeding. Okay, so this is why there is a bursting pain in the lower abdomen during menstruation with chocolate like discharge, saying that it is a case of endometriosis complicated by cyst formation. Okay, this shows that there is an endometrioid cyst. Now moving on, a 40-year-old female patient has been observing profuse menses accompanied by spasmodic pain in the lower abdomen for a year. Bimanual examination performed during menstruation revealed a dense formation up to 5 cm in diameter in the cervical canal. Uterus is enlarged up to 5 to 6 weeks of pregnancy, movable, painful, and of normal consistency. Appendages are not palpable. Bloody discharges are profuse. What is the most likely diagnosis? Okay, so let's get back to the discussion in the question. See, it is mentioned there is a profuse bleeding, okay, heavy menstrual bleeding. Along with that, there is dysmenorrhea, there is pain in the lower abdomen. And when we checked upon bimanual examination, we found that there is a dense formation up to 5 cm in dia in the cervical canal. Okay, so and also the uterus is enlarged up to 6 weeks. See, the lady is not pregnant, but when we see the uterus is looking like the lady is 5 to 6 weeks of pregnancy. That much uterus has been enlarged, and it is movable, painful, and the bloody discharges are very much high. So as I already mentioned, fibroids are something. Basically, what is fibroids? Fibroids are benign tumors of smooth muscles in uterus. Okay, so it is a benign smooth muscle tumor of uterus, fibroid. Fibroid will always present with increased bleeding, okay, dysmenorrhea, painful menstruation, and always not for the increased uterine size. Okay, so now let's see the options itself. Abortion in progress. See, there is nothing mentioned in question like the lady was pregnant or anything. Uterus is enlarged, but it doesn't mean she is pregnant, right? So there are no more other signs of pregnancy in the question. Cervical myoma is a smooth benign tumor which is seen in cervix. It can become infected, it can bleed, or even it can cause issue while urinating and all, but it does not present with this kind of presentation. Especially it will not increase uterus size. Okay, algodysmenorrhea, this is a preliminary diagnosis only. That means it's a painful menstruation. That is one of the symptom mentioned in question. There is nothing as a diagnosis. And already cervical carcinoma, we discussed the 4 cardinal signs, right? Fixation, contact hemorrhage, friability, All those 4 cardinal signs are discussed. Now the last option is a fibromatous node, nascent fibromatous node. Now what does it mean by nascent? Nascent means something is hanging out with the help of a peduncle. So this is why the fibroid which is in uterus is seen in the cervical canal. Okay, so the dense formation, the fibroid is actually forming in uterus, but with the help of a pedunculated sac, it is coming and hanging out in the cervical canal. So that is why we are seeing it over here. So let's see a picture, then it will be a little more clear. So as I mentioned, fibroids are smooth muscle tumors of uterus. There are different varieties. There can be a subserous fibroid, there can be submucous fibroids. Okay, and the case which we are discussing is a nascent fibroid. What is it? As I mentioned, there is a peduncle. From the pedunculated, with the help of peduncle, it will be hanging down in the cervical canal. So it is a pedunculated submucous fibroid. So always know the signs of fibroid: profuse bleeding, increase in uterine size, and abnormal menstruation. Okay, it can be increased bleeding, dysmenorrhea and all. Now moving on, a 20-year-old patient complains of amenorrhea. Objectively, we can find hirsutism, obesity with fat tissue prevailing on the face, neck and upper part of the body. On the face, there are acne vulgaris. On the skin, stria cutis distensae. And psychologically and intellectual development is normal. Gynecological conditions suggest that external genitals are moderately hairy. Acute vaginal and uterine hyperplasia is seen. What is the diagnosis? Okay, first of all, there is complaints of amenorrhea. Okay, lack of menstruation. Hirsutism means there is hair growth. Okay, so there is hair growth. And where is the obesity? The fat tissue is mainly seen in fat on face, neck and upper part of the body. And there is also acne vulgaris, and on the skin you can find particular stria cutis kind of striations. Now let me show you what is that striation. So this is how the stria cutis striations look like. Okay, and according to the question description, this is how the face will be, because they already mentioned the fat is prevailing in face, neck and back. So now I think you can get a very much clear idea about this. So first of all, if face, neck and upper part of the body having more fat, it means that it is giving a moon shaped face, right? Moon shaped face plus buffalo hump, because the neck and upper part of the body is having fat deposition. Along with that, stria cutis distensae. So now it is very much clear this is a case of Cushing syndrome, because we already know in Cushing syndrome it is an excess of glucocorticoids, right? It can be due to ACTH, dependent or independent. And always remember, in Cushing syndrome, moon shaped face, buffalo hump and stria cutis distensae, these particular striations. Along with that, there can be amenorrhea, hirsutism and all. So this is a very much clear-cut sign of Cushing syndrome. And now let me say something. What is actually Stein-Leventhal syndrome? This is another name for PCOD. Okay, so polycystic ovaries. In case of polycystic ovaries also, there is amenorrhea, there can be hirsutism, but the obesity is in a centripetal distribution. Okay, the obesity is in a centripetal distribution. It is not like the face or the neck or the upper part of the body. It is not like that. The obesity has a centripetal distribution. So there is more fat deposition in the abdomen and all. And what is the dermatological marking? See, in PCOD, there is always insulin resistance. Okay, because of insulin resistance, these patients have a particular skin hyperpigmentation known as acanthosis nigricans. So always remember, in PCOD also amenorrhea is there, hirsutism is there, as well as in Cushing syndrome amenorrhea is there, hirsutism is there. But where is the fat deposition? In PCOD, the obesity is in centripetally distributed, and the dermatological marking is always skin hyperpigmentation. Okay, this is actually a black colored hyperpigmentation known as acanthosis nigricans due to insulin resistance. But in case of Cushing syndrome, it results in the formation of stria cutis distensae. Okay, so these are the main points to be kept in mind. So that's it for today. Now we will see on next part with the rest of the questions. I hope everything is clear. Thank you.